Good morning, everybody. Welcome to this first session of this last day of Symposium. And it's a pleasure for me to chair this session that is expected to be really interesting, intriguing, and also very informative, especially for embryologists. And it was a pleasure for me also to chair with my co-chairman, Lodovico Parmigiani, but he had an inconvenience. He's sick, so I'm alone. I'm alone. But I have the fortune, I'm lucky because I have Dr. Borini with me, and so go on. And this session has a panel of outstanding speakers that will treat issues that are the hot topics of IVF. We can say that are evergreen topics. In fact, we know that laboratory is the base, the fundament of IVF. And we know also how much is important that embryologists never stop wondering if they are doing the best, and never stop searching for a permanent gravity center, as the title of the session suggests. We have 4 speakers. Each speaker has 20 minutes, and the discussion will be at the end. Now, I have the pleasure to introduce Roberta Maggiulli. She is a senior clinical embryologist, and she was also a researcher at the Weill Cornell Medical College, and now works as IVF lab operations director in General Life. And she will speak about automation, and the title of the talk is "Can automation improve the performance of the IVF laboratory?"
Thank you, Cristina. Thank you, Andrea, for allowing us to be here today. Yes, my talk will be about automation. So we will review some device and technology that can be applied in clinical practice to improve standardization. So we all know that even today, the ERT procedure are basically performed manually, thanks to the meticulous work of skilled embryologists that from the very beginning take care of gametes and embryo and focus on preserving their ability to develop. So we know that the clinical embryologist surveillance, vigilance from one side, and manual technical skill from the other side are really essential, really crucial in preserving embryo viability. On the other hand, we are all aware that the human element is per se a risk factor, since we know that human work has 2 major implications, because we have a high sensitivity to stress and intensive workload that can affect the operator performance, and we have a subjectivity in the assessment that can affect the inter-operator standardization. So basically what we can do at the moment to improve standardization is just to establish a very precise standard operating procedure and perform an accurate training for all our embryologists and try then to monitor their performance through the use of key performance indicator. And this is something we always do in our clinical practices. This is an example of what we do in Rome to monitor embryologist performance. Although we know that we have a lot of tasks in the IVF treatment that are highly repetitive, and we have often an intensive workload, so we have a high risk of human error. So to this regard, automation in the lab, introduction of automation in the lab can be helpful in order to improve or introduce standardization in order to ensure the quality of the IVF process and making the RT process less subjective less sensitive to operator performance. Automation can enable to improve the efficiency of the IVF treatment, allowing it to offer a controlled, stable environment for our gametes and embryos for each step of the process. And the introduction of automation may help us to improve the accuracy and the reliability of the data, with the final aim eventually to create a platform for artificial intelligence. So basically we have three main technologies that have been introduced so far in the clinical practice in order to improve standardization. Microfluidics is for sure one of the most promising approach, and it has been already used in the clinical practice in order to address for sperm analysis and selection, or site selection and denudation, insemination, embryo culture, vitrification. So it's very, very promising technology. We have seen yesterday that robotics has been introduced basically to standardize the ICSI procedure that can be, the results of the fertilization rate can be highly sensitive to the skill, the experience of the operator. And artificial intelligence, finally, that will not be the topic of this talk, since it has been already covered by Danilo in his talk, but artificial intelligence can integrate microfluidic and robotics in the development of a comprehensive system for automatic IVF. So as I said, microfluidic is a very promising approach, since it allows us for controlling and manipulating fluids in very low volumes. We are talking about picoliter to microliters. So it is a model that closely mimic the in vivo conditions. Basically, we have this lab chip made of a microchamber and a microchannel with culture media, and the continuous perfusion allow to change the culture media and leaving the embryos in place, but offer us the possibility to create a controlled dynamic culture environment. Basically, they are made of materials that, of course, they do not interfere with the embryo development, and they have the great advantage that since they can be integrated with a time-lapse system of or collection modules for the analysis of the spent medium. So this is one example of microfluidics chip utilized for sperm sorting. We have this chip that are already available for the use in the clinical practice. Basically, we have a chip, a glass chip, with an inlet and outlet reservoir that is connected by a microchannel. And the chip design imitating the path of the sperm to the female reproductive tract, so allow us to select the high-quality sperm on the basis of characteristics such as, for instance, the size of the sperm. Another approach can be used in microfluidic, that is the active selection of spermatozoa, that basically exploit the active swimming of the sperm, usually in response to a stimulus, so trying to mimic what the condition on the in vivo conditions. For instance, they exploit the chemotaxis response to progesterone secreted by the cumulus cells. So these are the two methods that can be used for sperm sorting. And we have some study already on human oocyte that have been performed trying to assess the efficacy of the system in selecting the high quality, the best spermatozoa for ICSI. The first study has been performed on sibling oocyte, and the second one was a prospective randomized control trial, so try to compare the efficacy of this system in selecting spermatozoa. But as you see in this table, both studies failed to prove the superiority of the microfluidic system in selection of the best spermatozoa when compared to conventional selection techniques such as, for instance, the swim-up method. So probably we need a more robust randomized study in order to prove the efficacy of this system. So all the techniques that we have mentioned so far are basically motility-based, so we need motile spermatozoa to apply this technique. But microfluidic can be also a technology that can be used to isolate viable spermatozoa in very difficult cases, as in the case that we have to isolate spermatozoa from testicular samples. We know that the search of the sperm in this case is a very challenging procedure. It can require a longer time. It is time-consuming and labor-intensive, and the chance to achieve it and to find a viable spermatozoa for injection is always dependent from the operator experience. So in this sense, microfluidic can help us to reduce the technical burden and variability in the selection of the viable spermatozoa from testicular samples. Microfluidic has been also applied to perform oocyte denudation. So we know that we basically, the inundation is performed manually, so in order to standardize this process, to reduce the stress to the oocyte, the on-chip oocyte inundation has been proposed, where the oocyte are denuded by mechanical constriction and then a suction force. And it seems that this mechanism, this application, this technology does not damage the fertilization and the ability then to develop of the new oocyte. This is a study that compares the fertilization rate and the blastulation rate of oocyte denuded on a chip compared to oocyte denuded with the conventional method. And as you see, both fertilization and blastulation rate are comparable regardless from the insemination technique that was used. So after denudation, we know that we have to select oocyte for insemination. So we have to select a mature oocyte and exclude those oocyte carrier of major malformation. And to this regard, microfluid device can help us in the oocyte quality assessment, since it has been demonstrated that good quality oocyte have a higher segmentation rate in SU-cross solution. So by having an inner, an upper, and a lower outlet, the good quality oocyte are collected from the lower outlet, since they have a higher sedimentation rate and seems to have higher competence to develop. So at the moment there are no devices that can replace all the manual steps of the IVF treatments, but to move toward this goal, some research groups have been trying to at least design a chip that can perform several steps of the IVF process. And this is one of the example, the microfluidic device, where we have an inlet and outlet port connected by a microchannel, and the microchamber that is basically a well-of-the-well system where oocyte can be placed in a single well. So basically, the new oocyte can be pipetted by the inlet port. They are then placed on a single well. Then by the same port, we can pipette the sperm suspension, so we can leave the insemination occur, and then we can follow the development of the single embryo. And this system seems to provide the same performance in terms of embryo development compared to the conventional microdrop culture system. So one of the main advantages of microfluidic can be integrated also with nanosensor for real-time media analysis. We know that the metabolic status of the cell is closely linked to its activity and its viability. So in order to improve our ability to select the best embryo to transfer, we can apply also nanosensor for real-time media analysis. We know that the metabolic activity has been correlated with the quality of the blastocyst and the ability to develop. So we can also monitor this marker in order to improve embryo selection. We know that the current focus in the field of human reproductive medicine is to develop a rapid, possibly non-invasive method in order to assess the embryo competence to develop. So in this sense, automation may help us in the future to improve embryo selection. One of the steps that is more sensitive to operator skill is for sure vitrification. We know that vitrification is a manual procedure that has very stringent requirements, and operators and the results, the oocyte survival can be different across centers, but also across operators belonging to the same centers. So the introduction of automation in vitrification may allow to standardize this procedure, achieving a gradual and continuous control of the change in the cryoprotectant concentration, so reducing the handling of the gametes and the embryo and the cellular stress. And this is one of the systems that we have already commercially available, the Gavi system, with a closed device that's called POD, where you can load up to 4 embryos. And it seems that it has been tested already on mouse oocyte first, and then on human donated embryos. It seems to provide the same pregnancy rate and miscarriage rate of the conventional cryotop method. So it seems that we are moving towards standardization. Probably we are not yet, since the implementation of this kind of system is still limited in the clinical practice. So this is because the still require a considerable financial investment, and moreover, they are not able to standardize and automatize all the steps of the procedure. So at the end of the day, when the author calculated the procedure timing, it was even higher for the automatic system compared to the cryotom method. So this obviously entails less staff convenience. So we have seen yesterday with Alessio the robotic system for ICSI. Basically, the robotics has been introduced with the aim to standardize the ICSI procedure. This is a robotic system that has been proposed just to make the selection of the sperm less subjective. And basically, we have here a motorized microscope stage that actually adjusts the orientation of the target sperm, so the direction of the swim is brought perpendicularly to the axis of the macropipette. So the success rate in terms of immobilization is pretty high, and especially the average immobilization time is 5 to 6 seconds. So this technique may allow us to speed up the process of sperm selection and immobilization. And eventually, it can be combined with a specialized software that combining artificial vision, artificial intelligence can identify, track, and quantify individual sperm motility pattern in real time. So it can provide us with a score, and it seems that this score may correlate with the potential of the sperm to support proper fertilization and embryo development. We have seen that, ICSI has been, the first automatic ICSI has been proposed in 2011 with a higher success rate in terms of sperm deposition and the survival rate. But even for this system, the application, the clinical practice is still limited. And there are new systems being proposed also for the blastocyst orientation to speed the blastocyst to speed up the procedure of the blastocyst biopsy. For the luckiest embryologist, automation can be also introduced in cryo storage room. The system is called Tomorrow. It's one of the systems that we have commercially available now, and it may help us to standardize the management of the cryopreserved materials. So it's a system that can help us to minimize the risk of incident due to the manual work, the manual handling of the cryopreserved materials, and also can allow us to maximize the traceability even in the cryo room, since each support, each device is labeled with radio frequency identification tags, so the cryo storage, the traceability can be ensured even during cryopreservation. So all the solutions that we have discussed so far are solutions that have a limited application in the clinical practice because of the cost, especially because of the cost, because we still need a proper validation for this system. There are some systems instead that are now part of our clinical activity. One of these is the electronic witnessing system. That emerges a new technology with the potential to standardize and maximize traceability during the IVF treatments. And this system has the main advantage to optimize and improve the lab efficiency by helping embryologists to monitor the exact sequence of the procedure and record in real time all the timing of the procedure and the completion of the procedures. On the other hand, the electronic witness system is also a valuable tool to monitor key performance indicators. So in our center, it is allowing us to define key performance indicators and then monitor the performance of the operator. This is just an example to show one of the applications of the electronic witnessing system. If we think about ICSI, it has been introduced 30 years ago. And it's a well-established procedure now, but there are still questions about the optimal time to perform the ICSI procedure, whether the oocyte pre-incubation is needed or not before insemination. So by using the electronic witnessing system, we were able to record in real time in a consistent way all the timing of the procedure, and we were able to see there is no impact of oocyte pre-incubation rate in terms of maturation of the oocyte. And we were also able to evaluate the operator performance in terms of time that the operator spend to perform the procedure. This is the example in Rome. We have 12 embryologists with different experience. So as we were expected, the results, the time that they spent to perform the procedure was different, even when corrected corrected for the number of the oocytes that were injected. But then we realized that if this timing is within a certain limit, the operator performance does not impact the laboratory and the clinical outcome. So we were able to observe then a delivery rate that was constant across all the operators. So in conclusion, we may say that in the IVF lab we have already RT diagnostic tools such as the computerized sperm analysis system and time-lapse embryo imaging that are already available. However, we are still far from achieving a comprehensive system able to automate the entire IVF process. What we need in the future is for sure a proper validation of this system because we need to prove that this system can help us to optimize the results and to obtain results that are superior to those obtained with the current manual process. So if we look to the future, what we would like to aim to reach is the lab on a chip concept, where we have a small chip that can automatize all the procedure from the gamete selection, gamete preparation, insemination, embryo culture, and eventually integrated this system with non-invasive analysis in order to select the best embryo to transfer. So this is just a consideration.
Closing, please.
Yeah, just a consideration for the future. The automation will not replace the need of the embryologist in the lab. So we will technical skill will become less important, but the embryologist will. We have to underline that automation is a multidisciplinary task and challenge. So we will need collaboration between embryologist, AI engineer, and bioinformatics in order to make this happen. So I would like to thank you for your attention. And
well, thank you very much, Roberta. Very fascinating, your presentation. Well, now it's time to introduce Dr. Catello Scarica. It's a pleasure for me. He's a senior clinical embryologist, and he's now the IVF lab director in a European Hospital of Rome, where he is a co-founder of New Fertility Group. He will speak about mineral oil, a key factor in embryo culture. Thank you.
Thank you, Cristina. Thank you, Andrea. I'm very glad to be here, and I will speak about this crucial aspect of culture system. Although it's very important, I'm at risk of bothering you about very specific topics, so I try to skip directly to the conclusion before starting, and so before you fall asleep completely during my presentation. I would like to say that oil, first of all, is rather than counterintuitively, is not completely impermeable to water. So one of the points that we will see during the presentation is that evaporation occurs even in the presence of oil overlay. And the other aspect that is very important is that oil is a source of toxicants, as we will see, and this is very sensitive to the handling that we do during the storage and the usage in our laboratories. We all know that there are several factors that are very important for the embryo culture up to blastocyst stage that can affect the blastocyst morphology or blastocyst stage. One of these, of course, is the oil overlay. The usage of the oil was introduced at the beginning of the 60s by two students of John Biggers that were Wattin and Brinster. just because at the beginning the success, following the success of using test tubes to culture embryos up to blastocysts, was changed using a petri dish by these two students and covering the culture media with the oil overlay to improve the observation during the embryo culture. And this was the usage of a simple, very simple oil at that moment, just to simulate a physical barrier from the external agents, and in particular for the evaporation. However, the oil is very complex. And there are several kinds of oils. It depends by the crude oil distillation procedure by which derive the mineral oil. And there are different compositions in the pure oil that we use in the laboratory. Essentially, we can distinguish two fractions from this process, that is mineral oil saturated hydrocarbons, the MOSH, by which derives the paraffins that we use in the laboratory. The other one are the mineral oil aromatic hydrocarbons that are not so present in the medical field, okay, the usage for the medical purposes. I would like to underline that a clear nomenclature recognizing paraffin and mineral oil is still missing, because the pure composition is very difficult to distinguish during the distillation process. So in our laboratory, usually we use the term paraffin or mineral oil overlapping and not distinguishing very well this kind of components, because in literature there is not a clear nomenclature. So using or choosing the right oil for our culture system should be based about the purity, viscosity, density, and in particular absolute water content of the oil, as I will show you after. One of the main problems is the handling and storage of the oil in the laboratory. They are very sensitive, as I told you before, in particular to UV and light exposure. And even if they are sold by manufacturers as completely pure, some traces of contaminants could be present. And these contaminants could be improved or increased during the manipulation in our laboratory. So we have to be very careful during all the usage and manipulation. And to avoid the risk of contamination, some procedures have been introduced to improve mineral oil handling. First of all, the washing of oil. This is an old-fashioned kind of using oil. In our laboratories, at the beginning, it was useful to wash with water, pure water, or culture medium oil before the usage. Actually, this is because, in particular, there are many papers about this topic. I reported one in particular about the Morbek, in which unwashed oil performed not so good in terms of blastocyst stage compared to washed oil with several kind of washing with medium or water, and also the oils with contaminants like the X100, that is a detergent, was after washing showed lower amount of contaminants inside. So this procedure seems to be safe, and yet in the 2012, many producers started to wash the oil before the delivery to our laboratories. And actually in 2022, after 10 years, I'm quite sure that the majority of the manufacturers are washing their oil before introducing them in the laboratories. Should we introduce again the washing in our lab? I think no. The less manipulation, the better. So, depending on the type of oil, we have to refer to manufacturer quality control and or the correct management procedure that they suggest. Let's go to the most important part of this topic, the usage of oil as a stabilizer of culture conditions. Several studies by Spain and Jason Spain and his group demonstrated that media evaporation occurs even in humid incubator. humidified incubators, in particular without oil, they record a pH increase. Meanwhile, with oil overlay, the pH is more stable. And in 2019, Jason Spain produced this paper considering the risk of uninterrupted embryo culture. And some of the problems that he analyzed in embryo culture system is the oil volume, oil density, oil quality. This is very important to reach a stable embryo culture up to blastocyst stage, in particular with the new technologies of new benchtop incubators that in many cases are not humidified. In another study, he demonstrated also that evaporation from culture media can still occur even under mineral oil overlay. In fact, in dry incubators compared to humidified one, he analyzed that drops of 25 microliters of culture media under 3 ml of paraffin oil increased their osmolarity after 6 days of embryo culture, even with an oil overlay. But the interesting thing was that increasing the volume of oil, this effect quietly disappeared. So the volume of oil can affect the evaporation rate in non-humidified incubators. In this recent paper, there were 4 oils that were compared for the property that I introduced you at the beginning, the water content of oil. And interestingly, the authors found that the oil that had a lower water content and a lower water active value showed an increase of osmolarity during days of embryo culture. So this is a very important thing. They also concluded that humidifying or pre-equilibrating this oil, this effect slowly disappeared. So it's important to understand what are the characteristics of oil, also to manage it the better in our culture system. This very recent paper from Mestres and colleagues from the Embryo Tools group showed also that the volume of oil confirmed the fact that evaporation still occurs even in oil, under oil overlay, but in particular, they showed that osmolarity is completely preserved by just increasing the volume of oil under oil overlay under which we put our embryo in culture. I'd like to show you also this paper from Mullen that is interesting. He focused on viscosity, density, and also the thickness of oil that we put on our culture media. He showed that the higher the viscosity, the higher the density, the higher the lower the osmolarity increase. And more interesting, 1 millimeter of thickness of oil on our culture media can be detrimental in terms of increasing osmolarity. This effect seems to disappear when we increase the thickness of oil, the volume and the thickness, so the surface between air of atmosphere and our culture drops. Mullen also performed a mathematical model using all this information to predict which kind of evaporation and change in osmolarity we can expect using a type of oil with a certain density, viscosity, and the thickness of that we use to do the plate. This is to predict in a new culture system, for example, to set up the culture system, what we have to expect and how to adjust the volume of oil. Looking at all these characteristics, we produced a review this year, and we summarized all these features about the oil usage, and also suggesting some tips and tricks. So if you want to deeper know this kind of information, this review summarized everything. And the other important thing is that oil is a source of toxicants. Yet in 2007, 2009, this group produced some good evidences about the presence of VOX inside oil, like a reservoir of oil, of VOX. And in the first paper, they demonstrated also that the peroxidation, that is the major source of oil toxicity, and it involves also the production of free radicals, are increased in the oil overlay, in which albumin is like a receptor for that make it passes between oil and the zona pellucida and could affect the embryo development, as demonstrated in terms of drop of blastocyst production in high peroxided oil embryo culture. Last, I want to show you this recent paper from the embryo tools group Mestres, in which they analyzed an important problem, because peroxidation can occur because sometimes also very purified oil can present in traces peroxidation that can increase during the handling in our laboratories. But the problem is the detection of a peroxidation at the beginning. The MEA test seems, the mouse embryo say that usually the manufacturer perform before the oil production, selling, are not so sensitive to traces of peroxidation. It was demonstrated by these authors in this paper, and they produced a very tailored mouse embryo assay test that usually is performed using a culture medium in which mouse embryos are cultured up to blastocyst stage with the bovine serum albumin that seems not to be sensitive to the peroxidation free radicals in the oil. Instead, they used human serum albumin, and this, as you can see, is very sensitive to the percentage of peroxide value, peroxidation value. So the blastocyst rate, formation rate, dropped down in high peroxide or few, with a low peroxidation value in the oil. So they proposed this kind of adjusted MEA test only for the right assessment of mineral oil before the usage in our laboratory. In our review, we produced also a sort of checklist in which we suggest some tips and tricks for the handling and the storage, and also the usage in during the embryo culture. As a key take-home message, I can say that we have to tailor and consider more important the oil in our laboratories as the culture media actually are, but it is a very important component of our culture system. So if you have any questions after, I will be happy to discuss you about this crucial aspect of culture system. Thank you.
Thank you very much, Lello. Very interesting, very intriguing. Okay, move on with the next speaker. He is a senior clinical embryologist and is the IVF lab director at 9.baby of Bergamo. He will speak about a controversial topic question, which is the non-viable embryo.
Thanks, Cristina, for your presentation, and good morning to everybody. So, the topic of my presentation is the non-viable embryo. How to define a non-viable embryo is a challenge for IVF practice. This definition is very important because it has many implications: legal, psychological, ethical, religious, and financial. But unfortunately, to date, this definition is still unclear. Moreover, it's very important in the specific country that have a specific regulation, like in Italy. In Italy, we have a law that don't permit to discard one embryo if this embryo is not defined and non-viable in terms of mitotic arrest or degeneration. So we must cryopreserve any developmental embryos, but in this way, we have many affected and or aneuploidy embryo, clinically not usable, but cryopreserved and stored indefinitely, with financial implication for the IVF clinic and ethical and psychological implication for the patient. So for these reasons, it's very important to find this definition. Previous authors failed to define a non-viable embryo because, for example, Alicani in 2005 affirmed that blastomer fragmentation, degeneration, mitotic arrest, and multinucleation during early cleavages might associate with a lower competence. Yes, but they are insufficient to clearly identify a non-viable embryo. Furthermore, in 2009, Gavrilov and colleagues affirmed that those embryos that had arrested or failed to divide normally and or were morphologically abnormal were deemed non-viable. But again, this definition is not correct because embryo morphological evaluation cannot define absolute absence of competence. In fact, we know that to date, the poor quality blastocysts have a chance to achieve a live birth. In this interesting paper published on the human reproduction in 2019, Cimadoma and colleagues show the difference in terms of live birth per single euploid transfer between poor quality and non-poor quality blastocysts. The authors show the significant difference between two groups, but if we see the result on this table, the poor quality blastocysts have more or less 11% of probability to achieve a live birth. So in a summary, any embryos that develop to the blastocyst stage, regardless of its morphological quality, might be euploid, diploid, and can result in healthy baby. But what information can we use to define a non-viable embryo in our daily routine? Let's start from the day of blastulation and blastocyst quality. Many recent papers talked about this topic, the real important to extend your embryo culture until day 7 blastocyst. The result in terms of euploid, ongoing pregnancy, and the live birth rates are lower in day 7 when compared with day 5 or, for example, day 6 blastocyst. But these results suggest to not discard these embryos with a slower development. In fact, if we see the result on this table, the poor quality blastocysts on day 7 have 13% of probability to achieve a live birth in a single euploid transfer. So, the day of blastulation and blastocyst quality are associated with a lower competence, but they are insufficient to identify a non-viable embryo. And time-lapse technology? Time-lapse technology in the last decades provided new information about embryo development. And this information is very important in order to identify and select the best embryo to be transferred. But the question now is, can this information help us embryologists to identify a non-viable embryo? Time-lapse technology allows us to pinpoint abnormal cleavage patterns during preimplantation development. For example, cytokinesis failure, direct tanical cleavage, chaotic cleavage, or reverse cleavage. These abnormal patterns have a lower blastulation rate, yes, but have a chance to reach the blastocyst stage and have a chance to achieve a live birth. In fact, if we compared direct tanical cleavage with the known direct tanical cleavage embryos, direct tanical cleavage have a lower blastulation rate, but have a chance to achieve a live birth. And what about their chromosomal constitution? Direct tanical cleavage embryos have a lower euploidy rates at the cleavage stage, but not at the blastocyst stage. And this is a very important information because it means that if direct tanical cleavage reach the blastocyst stage, they seem to be as competent as non-direct tanical cleavage. So, abnormal cleavage patterns don't identify absolutely a non-viable embryo. Now, let's talk about abnormally fertilized oocytes. This is an interesting paper published on fertility and sterility in 2017, talking about the possibility to achieve a healthy live birth from abnormally fertilized oocytes. In this paper, Capalbo and colleagues don't analyze the 3 Evelyn size PN, but only 1 PN at 2 Evelyn size PN plus 1 smaller PN. If we see the result in terms of absolute numbers, in 1 PN and 2.1 PN there are blastocysts, we have a high probability to have a diploid blastocyst. Moreover, overall in this study, 31% of transferable embryos were obtained from abnormally fertilized oocytes, and some of these achieved a live birth. So we conclude that euploid, diploid blastocysts obtained from abnormally fertilized oocytes are reproductively competent. So I think that to date, the only reasonable strategy to assess embryo competency to identify a non-viable embryo by deselection is extend your embryo culture until the blastocyst stage. Because if you extend embryo culture up to the blastocyst, this allows a reduction in the number of cryopreserved embryos and embryo transfer performed, but you have a comparable miscarriage and cumulative live birth rates respect the 3 embryo transfer. But what are the opinions of scientific societies? In 2011, Escher and Alpha published the Istanbul Consensus, and at the end of this consensus, the panel of experts defined a non-viable embryo as an embryo in which developmental has been arrested for at least 24 hours, or in which all the cells have degenerated or lysed. This is the first official document about a non-viable embryo. Then, in 2018, American Society Reproductive of Medicine published another important opinion paper about blastocyst culture and transfer. And the experts conclude that the reliable criteria to identify embryos destined to develop to viable blastocysts in vitro remain to be established. But important researches are ongoing. In fact, last year, the 2 Italian scientific societies, SIER and SIGU, published another important opinion paper about this topic. In this case, the 2 societies called these embryos developmentally incompetent preimplantation embryos. Why? Because for the first time they introduced in their definition a new point of view, affected embryos. In fact, their definition of developmentally incompetent preimplantation embryo is an embryo derived from 3 PN or more, developmentally arrested and degenerated embryos, and embryos affected from specific anomalies. This is, for example, a new point of view respect to the previous definition by Escher and Alpha. And another different point of view is when the 2 societies talking about developmentally arrested, because in this case means 48 hours after the previous observation, while Escher and Alpha said 24 hours. So this different point of view highlights that to date there isn't a consensus about this definition. But what is the optimal timing in terms of mitotic arrest in order to define a non-viable embryo? Because Escher and Alpha said 24 hours and SIER and SIGU said 48 hours, and the 2 timings are very different. This is an interesting paper talking about the transient developmental arrested embryo. So these embryos that have the 2 same consecutive observations in 24 hours and that then resume their development and reach the blastocyst stage. In this study, the transient developmental arrested embryo have a lower implantation rate in fresh or frozen embryo transfer when compared with continuous developmental embryo, but the chance to implant. So this data, this result suggests that 24 hours could not to be the optimal timing in terms of mitotic arrest in order to define a non-viable embryo. So I think that the definition of non-viable embryo today remains an open question. Now I am at the end of my presentation. Embryo morphological assessment, day of blastulation, abnormal cleavage patterns during preimplantation development, and abnormally fertilized oocytes cannot absolutely identify a non-viable embryo. Mitotic arrest and degeneration are the only reliable criteria to define a non-viable embryo, but there isn't a consensus about the optimal timing in terms of mitotic arrest. And in the end, I think that the only reasonable strategy to assess a non-viable embryo by a deselection, physiological deselection in vitro, is extending your embryo culture until the blastocyst stage. Thank you very much for your attention.
Thank you very much, Alessandro, for your very clear and informative talk. Move on with the last speaker. It's an honor for me to introduce Ioannis Sfontouris. He's the founding member and the director of embryology laboratory at IGEA IVF Embryogenesis, the largest private IVF clinic in Greece. He's an honorary assistant professor in clinical embryology at the University of Nottingham. He is a past, but not so past, he's a recent past coordinator of SIG Embryology of ESHRE, and he is associate editor of the journals Human Reproduction and Frontiers in Reproductive Health. Okay, he will speak about media, single media versus sequential embryo culture, technicalities and outcomes. Thank you.
Cristina, thank you very much for your very kind introduction. I would like to thank Giovanni Coticchio, Andrea Borini, and the rest of the organizing committee for your kind invitation. It's a pleasure for me to be here with you in Bologna, and I hope that at some point in the future I will be able to return the invitation and you can come to one of our meetings in Athens. So in order not to spend valuable time for my talk, we should start. So I'm going to address an important topic, and this is the topic of the embryo culture medium that we use for extended embryo culture in the IVF lab. So with the advancement of new generation culture media, we are now able to sustain successfully the entire pre-implantation embryo development in the lab. So this is very important, though, because although the embryo may be able to develop and reach the blastocyst, the crucial question, as we heard from the previous speaker, is to have a viable blastocyst that is going to lead to a successful pregnancy and a live birth. So the concept of the comparison between single and sequential media is only valid when we think about blastocyst culture. So blastocyst culture has brought a lot of advantages in the IVF lab. So we have improved embryo selection. Allegedly, we get better synchrony between the embryo and the endometrium. The PGT cycles now, all the biopsies are done at the blastocyst stage. We make cryopreservation more efficient and cost-effective. It increases flexibility in the IVF lab and also allows more time to monitor high responder patients for the development of HSS. However, blastocyst culture is not very simple and not easy. It requires optimal laboratory setup. You need enough incubator space, you know, good capacity. You need to check your filters, and also regarding the culture conditions, the composition, the formulation of the culture media. We need to check the pH, the humidity, oxygen tension. So things like that are all very important and will make the crucial difference between having a successful blastocyst culture system or not. So the development of the embryo in the culture medium is very dynamic. So depending on the food that we provide in the culture medium, then the embryo is going to metabolize, so it's going to uptake and produce several things in the culture medium. So it's very important that the formulation of the culture medium is optimal. The first attempts to culture and transfer blastocysts in the early 90s were disappointingly unsuccessful. Although they did achieve some blastocyst development, the rates of implantation in pregnancy were disappointingly low. At that point, they used single media, but very simplified. So it was basic media like Earl's ballast salts solution, T6 or MEM. So these first attempts were not very successful, so it was not before the end of the 90s with the work of Gardner and Lane, who developed the concept of sequential media when blastocyst culture became a reality. So there is this very popular review published by David Gardner and Michelle Lane, and they describe all the basics regarding the development of the blastocyst. So the sequential media, the concept of the sequential media wants to address the changing metabolic requirements of the embryo as it develops from the fertilized oocyte up until the blastocyst stage. So the sequential media, we all know, includes two types of media. So one cleavage medium to culture embryos from day 1 to day 3, and then a blastocyst medium to culture embryos from day 3 up until day 5 or day 6. So the concept is to have stage-specific media to try and mimic the different conditions that the embryo is exposed to when it is present either in the fallopian tube or when it reaches the uterine cavity. However, single media made a comeback at some point at the beginning of 2000. So there was renewed interest in single culture media. We had new formulations, we had new components that made the culture in single media successful. So that was a turning point, because at that point it started a kind of competition between single and sequential media, which actually questioned the need for sequential culture. So the principle of the single media is let the embryo choose. So what we do is we provide all the nutrients from the start, and then we let the embryo choose what it needs and what it doesn't. And actually there are two fashions that we can use the single-step media. So it's the two-step culture, in which we replenish the medium on day 3, or the single-step, which is the continuous uninterrupted culture up until day 5. Regarding the composition of the culture media, either single or sequential, we know that there are significant differences either between sequential and single-step media, but also between single-step or sequential media between themselves. So Dean Moorbeck has done a lot of work in identifying the different components of the culture media, and we can see that there are differences in very vital components like glucose, lactate, and pyruvate, all of which are bound to have some effect in embryo development and blastocyst formation. So this table is taken from a paper from John Biggers and Summers, published in Fertility and Sterility, and shows us a comparison between non-renewed and renewed culture in single media versus sequential media. So we can see that there are a lot of concepts that we have to think about when we try to choose which medium we are going to use. So the advantage of a single medium is you can achieve an undisturbed culture, a lower stress to changing the medium from one type to the other, and you can save time from changing the media, prevent possible mistakes during handling. But at the same time, if you leave the embryo in the same drop of medium for 5 days, you cannot avoid having accumulation of potential toxins, for example, okay? So all these things have to be taken into consideration. And also a very important factor that these days I think is actually the most important factor that is going to define if we choose a sequential or a single-step medium is if we use time-lapse or not. We know that time-lapse is very compatible with a single-step medium. It facilitates continuous and undisturbed culture throughout the pre-implantation development. So I think that if you use a time-lapse system, the majority of labs are going to have a single-step medium. So it has been an area of controversy, single versus sequential. The question has been around for many years now, and there are many studies that have been published with various results. So we published a meta-analysis in 2016, and we wanted to compare the efficacy of the single and sequential media. So we identified 20 eligible RCTs that were randomizing oocytes or embryos, and 4 studies randomizing patients. We saw that there was an absence of a difference regarding the ongoing pregnancy rate between single and sequential media. So ongoing pregnancy was similar in the 2 media. However, we did find a beneficial effect in favor of the single medium when it comes to the blastocyst formation rate. There was a higher blastocyst formation rate with a significant difference in the single medium compared to the sequential. However, there was no difference in the number of good quality blastocysts between the 2 media. Overall, the quality of the studies, the quality of the evidence was not very good, so the majority of outcomes, the quality of evidence was low to very low, and the conclusion was, at present, there is insufficient evidence to recommend either sequential or single-step medium for embryo culture. So what about the cumulative pregnancy rate? One might think that, okay, if I have a higher number of blastocysts, then I might end up having a higher cumulative pregnancy rate. This doesn't seem to be the case. Danilo Cimadomo published a study in 2018, and they showed similar cumulative delivery rates using either single or sequential media and similar neonatal outcomes. Same results in a previous study by Sire, similar cumulative clinical pregnancy rate. And the same goes for a comparison between interrupted and uninterrupted fashion when we use single-step media. So if you change your medium on day 3 or not, you're bound to have similar blastocyst formation, similar morphokinetic timings, and similar clinical pregnancy, implantation, and live births. However, if we dive a little bit deeper into the embryo biology, then we will see that there are differences. What about embryo gene expression? There are differences there. There was a very interesting study comparing HTF, which is a rather simplified single medium, versus the sequential G5, and they found that there were 951 genes that were differentially expressed between the 2 media, and these genes involved several functions like apoptosis, protein degradation, metabolism, and the regulation of the cell cycle. So gene expression of human embryos is affected by the type of culture medium used. Regarding the birth weight, we know that in general birth weight seems to be affected by the type of culture medium. This also appears to be true when we compare single and sequential media. Again, a comparison between HTF and G5 showed that embryo culture in a sequential medium resulted in a lower birth weight compared to the single medium, the HTF, and more singletons were born preterm in the sequential medium compared to the single medium. A very recent study published just this year in Fertility and Sterility from the States showed that the single-step medium was associated with an increased probability for gestational age, but all the rest of the obstetric and perinatal outcomes were similar between single and sequential media. So placental abnormalities, pregnancy-induced hypertension, gestational diabetes, prematurity, small for gestational age or birth weight were similar in the 2 types of medium, which is very reassuring. What about epigenetic modifications? Although this is a little bit difficult to study in human embryos, we have very interesting data from animal models, and in this instance there's this very good study from 2016. They used rabbit embryos, and they compared embryos that were grown either in a sequential medium versus a single medium, global, or produced in vivo. So they found that the patterns and the kinetics of methylation and hydroxymethylation were different between the 2 media themselves and also compared to in vivo, which shows that no medium can closely mimic in vivo profiles. And if you see in these graphs, we can see that in vivo rabbit embryos, have an increase in their methylation between the 2 and 4 cell stages, and then methylation declines. However, the profile, when you culture in the sequential G1, G2, and the single medium, the global, we can see that this pattern of methylation is totally different, which shows that epigenetic modifications are different. What about the morphokinetics? Again, the answer is not very clear. There are some studies that show a faster embryo development during the first mitotic divisions in the single medium compared to the sequential. So there was shorter cleavage time for PN fading T2, 3, 4, and 5 in a single medium compared to the sequential. And also another study, a more recent study, found an accelerated first mitotic cycle to the 2-cell stage in the single medium. On the other hand, other studies have found no difference in the morphokinetic parameters between single and sequential media. But we have to think that comparing media is not an easy task. The thing that we are doing pairwise comparisons between single or sequential or this medium and that medium doesn't mean that the outcomes of that particular pairwise comparison is valid for all other media. So this is a very interesting and very nice review by Mandiku, published in Human Reproduction Update, and they highlight this very problem, that there are many numerous comparisons, and the results from comparing two media may not necessarily be valid for different media, which shows that it's very complex and it's very difficult for us to give a definitive answer on which medium is better. So, reaching the conclusions regarding the comparison between single and sequential media, we know that both types of media appear to be equally capable of supporting embryo development in vitro. It does seem that single-step media may give us more blastocysts, a higher blastocyst formation rate. However, pregnancy and live birth rates are similar between the two types of media. We know that gene expression and epigenetic modifications and birth weight are affected by the type of medium. Regarding the neonatal outcomes, it looks very reassuring that they are similar between the two types of media. It was only a slight increase in the odds of LGA observed with culture in single step. Differences in morphokinetics remain controversial, and we are still uncertain on which type of media is the best for embryos. So the answer is that it will depend on your laboratory practice, your laboratory setup, and primarily if you use a time-lapse system, that is going to define your choice between a single step or a sequential medium. So the answer is we do not know yet which medium is best. So I would like to thank you very much for your attention. Again, thank you very much for your kind invitation. And you have the kindest regards from our lab team in Athens. Thank you very much.
Thank you, Ioannis, for your very, very interesting presentation, very informative. As expected, the session has been very, very stimulating, so discussion is open.
First question, Valerio.
Yeah, I'm here, but this is Valerio. Can you go?
No, doesn't matter. Go ahead, Sergio.
No, there are several questions for all of you, but anyway, we try to select someone. The first one was for the first speaker. It was very exciting to see the overview he was presenting for the new tools we can use in the lab. And the question is if you have any favorite playlist on the techniques that you see could be in terms of efficacy and feasibility.
Thank you for your question. In my experience, the process towards standardization is going to be very, very long. We have seen, even with artificial intelligence, we need a sort of validation of all this technique. So what I think is that probably the best application that we will have in terms of automation is for sure the automatic system for witnessing, and probably I'm sure that also in the management of the cryo storage and the management of the cryopreserved material, robotics will help us in the future. For microfluidics, although it's a very promising approach, I think we still need a process of validation, because most of the studies have been published on mouse and mammalian oocyte, so we need to validate it. And we have to reduce the cost, because I mean we have a lot of advantages, but we have to prove the efficiency of the system and then try to have a feasible cost to introduce in the clinical practice. Otherwise, I don't think it's going to be easier to improve standardization in this sense.
Yes, if you can add, for example, an example, you was showing that one selection system could be the sedimentation of your sites according to the weight at the compactation. Well, we are developing a very sophisticated system to do this, and simply we see that zona pellucida is going to change the life quite quickly. So sometimes the zona pellucida can weight differently. It is not in according to the compactation of the cytoplasm.
Yeah, we're still learning, still need to validate this system.
Okay.
Valerio?
Roberta, I got a question for you. I really appreciate your talk. And I was thinking, when you spoke about the technology and the introduction of new technology in our laboratory, that some of the technology that you propose are not so recent. I'm thinking about, I don't know, the automatic solution for denudation, something like that. The paper was in 2004, more or less. So, for other kind of technology, like time-lapse, now we have in routine practice, not for this kind of automatic solution. What is your opinion about this? Do you think that this kind of technology will never come in our practice, or why?
I think they will do it, but as I said, it's not going in the proximate future, so probably we need time. And of course we need to train. No, we had a lot of expectation about the vitrification, the automatic vitrification procedure, and we were expected to see an improvement in the results, or at least comparable results, but in an advantage in saving time for the embryologists. Instead, we say that we couldn't reduce the cost. We had a problem in the storage of this device, and moreover, when embryologists have been interviewed about which method they prefer to perform cryopreservation, they answer the manual method. So I think it's going to be a very long process. In my opinion, probably the best solution is going. The first solution that we will apply is the automatic system for embryo culture, integrated with system to analyze the medium after the embryo culture to predict embryo viability. So probably in that sense we may need not a very long train also for the embryologists, because I mean it's going to be to automatize and improve the embryo culture system that is already been in some way automatized with the time-lapse system.
Thank you.
Sergio, in the meantime, I ask, don't you think that the embryologists pushed against the automation?
We are scared about it.
Yeah, because you know, the clinician, or anyway, who is in charge for the lab, probably wants to have the new technology. Now is also fashion, but which is the mood of the embryologist, because you know, if you save time, if you save work, you leave your powerful. So
we're not against.
My feeling is that someone is against, push against.
No, sometimes you need you spend a longer time to correct what the automation proposes. You see the case of the sperm analyzer for the automatic sperm analyzer system, and so we have it in the lab, but sometimes we spend a longer time to correct what the software says in order to have.
It's most costly, yeah. More and more costly. So.
and
Yeah,
consume.
to Ioannis. What about sequential atmosphere? Because you also mentioned about sequential medium, but in the animal story, we have to see that sometimes you need to culture in 5% oxygen or 6% oxygen in the beginning, and you need to move to the 20% when the medium became very complex.
Well, there is a lot of data out there that shows that, at least for human embryos, if you want to get high blastocyst rates, it is preferable to culture under low oxygen tension, so 5%. 20% oxygen doesn't seem to be as efficient as 5%, both in single step and sequential media. So I think that the norm for all laboratories these days is to either use a gas, pre-mixed gas, or a gas mixer to reduce not to use atmospheric oxygen, but reduce it down to 5%.
Thank you.
Lucia?
For Ioannis, please. I was thinking the same that Sergio asked, because a couple of years ago, the last ASHRE we did in presence, I remember there were 2 talks on 2% oxygen culture. And they suggested to culture 5 and then 2 and then back to 5. No, they didn't go back to 20, but they suggested 2%. So coming to my questions, I can ask the same probably to Lello, but I have a conflict of interest since I'm a co-author of the review. So I will ask to Ioannis. When you talk on sequential media versus continuous media, at the beginning, I mean, it's not the beginning, but the beginning back. So we used to culture in big wells, and then we moved to droplets, and now there are some suggestions to go back to wells, but I think it's not the story, because many people now is using time-lapse, and so we are going back to droplets and even small droplets. When the story of continuous medium came back after the good moment of sequential media, where it seems that everything has to be with sequential media, there are some companies suggesting to use big droplets. How do you feel this? Because I think this is not efficient. So if you have a different approach in culture, and the embryo has to choose in any single time what to take or what to discharge, if you enlarge the volume, this doesn't help. As the same when you were collecting in droplets with the oil, if you have the oil thick, but you have a 4-well, you have a convexity in the middle. So in the middle, you don't have the same thick oil. So the balance between oil and droplets in sequential media compared to single media, how do you see the thing?
Well, I think that this recommendation by the manufacturers to culture in larger droplets when you use group culture. So when you culture, say, up to 5 embryos, I think they recommend using a drop of around 50 microliters. I think that the story lies somewhere in the middle. I do not believe that there is an issue of depletion of nutrients and metabolites, because a drop of medium is like an ocean for the little tiny embryo. However, if you culture a group of embryos in the same confined drop for 5 days without change, then you have the production of other toxins as well. You have ammonia. So I think the recommendation is to culture in a larger volume when you have multiple embryos, in order to counteract that fact. Although I think that now there's a tendency to culture embryos individually. So then again, we are thinking the opposite. Is a 20 microliter drop too big for a single embryo? Because there's also the fact, the concept of the beneficial effects of the autocrine factors that the embryo produces. So if you have a smaller droplet, then you have a more concentrated presence of these factors. So it's not an easy answer. I mean, it depends on what you use and what type of medium, if you use group culture or single embryo culture, and that will depend on the size of drop that you might want to make. Although now with the time lapse, this is what we use. We have a specific dish. We have a specific culture volume that we use. Although these new dishes are trying to mimic a co-culture effect, while at the same time maintaining the embryos separately in individual wells. But as we have mentioned in the time-lapse recommendation paper that published a couple of years ago with Esre, it's also about the distance of the embryos. So it doesn't seem that the distance between the wells is small enough so that the embryos can communicate and share this co-culture effect. It seems that we cannot have a co-culture effect in the current setup of the time-lapse dishes because the embryos are too far apart.
Yes, John.
Alessandro, well, in the first place, thank all the speakers for entertaining us with their talks. Alessandro, you haven't included 0 p.m. in your talk. Do you have strong feelings for or against that?
This is an interesting question. I don't introduce the 0 p.m. because I think that on the data, the result about, for example, live birth, ongoing pregnancy from 0 p.m. published to date are data from no time-lapse technology, but only the check-on fertilization, standard fertilization. So I don't introduce this topic, this part of topic, because I don't have possibility to conclude, to have a conclusion, an important endpoint, because if you don't have a check by time-lapse technology, for example, it's impossible to arrive in a conclusion. But I think that 0 p.m. that reach the blastocyst stage and achieve a live birth, I think that now maybe it's impossible to see, okay? So I think that 0 p.m. is a non-viable embryo. It's then divided into maybe 2 or 3 blastomers, but it's not a normal division, but maybe chaotic division, and I don't never see the 0 p.m. that reach the blastocyst stage in my opinion.
Valerio?
Yeah, I have a quick question for Alessandro. Related to the laboratory that don't have, unfortunately, the time-lapse technology, as you correctly suggest, in my view, the best strategy to understand if an embryo is viable or not is to wait blastocyst stage. Yeah. But blastocyst stage could be day 5, day 6, or day 7. Do you suggest to wait every time day 7, or?
Yeah, because in this case, the discussion is different, because I think that day 7 blastocyst is a blastocyst or embryo with a lower embryo competence. So, but have a competence. Lower, but have a competence. Not viable embryo is an embryo that don't reach the blastocyst stage, or that don't achieve never, for example, live birth or healthy baby. So I have this is my opinion. I think that the blastocyst culture to date is the only reasonable strategy to assess via the selection, and yeah, day 7 blastocyst, I think.
I have a suggestion for you that you work in the lab as an embryologist. I think that you have to make the statement of the viable embryo very simple. Because if you start to look at day 6, day 7, day 8, or up to the necrosis is going on, a lot of you will go in jail just because throw away the embryos on day 3. So you have to think that in Italy, for example, but probably is a problem also in the other countries. If you throw away on day 3 a 6 G4 embryo, you really can say that never will go to day 7 blastocyst. So is that a viable embryo or not? So please, we thought a lot of time with Julia for just to define the viable embryos. Don't be so much in the deep, because if not, you are very, very in trouble. Very, very in trouble. So here we are in a contest of shines, of course, but the only viable embryo is the child that is born. All the other one are, I don't really think that are viable embryos. That's keep in mind this, please. I don't know what you think, but it's a big problem.
No, just if I may, maybe Valerio was not saying that you have to pull the culture through day 7 for all the embryos arrested, but in the DAC definition of our paper with SIGU, we claim that you have to wait till 48 hours after the first evaluation, so you can throw away on day 3 if it is 2 PN or 1 cell, and you can throw on day 5 if the 6 cell is still 6 cells.
It was not just a statement or a comment on Valerio's point of view, on Valerio's question. It's just that how many centers cultured up to day 5? Can we say that center that doesn't culture to day 5 are in contrast with the legal in Italy? So please close all the lab that just transfer on day 3 and don't culture to day 5. So it's a matter of thing that you have not to go too deep on day 3. If you have not the culture to day 5, if your embryo is not really growing well from day 2, you have to throw away, and nobody can say that you have to see if the embryo will grow up to day 7. So that is very important, because if we state something different, we need to have all the lab that culture embryo up to day 5. All the lab. So that is, if you think about it, it's very difficult. Sergio?
Yeah, with this I would like to involve Catello, because it's not working at the moment. No, the story that I guessed an Australian colleague in my lab for embryo production in animals. And the first thing she was said was, I will bring my oil. So she was carrying the oil from Australia. And I said, come on, you are bringing the oil, it's not so crucial. So we had a 20% difference. So I believe that you were stressing. But in your knowledge, there is any surrogate that we can use instead to use the oil, as you showing, can exchange a lot of things with the paracrine secretion with the embryos, you know, hormones, steroids, all the heavy metals, a lot of bullshit things.
Thank you so much for this question, because for a question of time, I didn't show an interesting part of papers about the in vitro maturation effect of oil on in vitro maturation results. This is due to peroxidation. This is due to the fact that oil can deprivate culture media from hormones during in vitro maturation. So this is demonstrated that is very crucial during this process, and in vitro production of bovine or equine embryos during these procedures. So in my knowledge, the only thing that has been performed is using antioxidant inside of oil. I don't know if there are any surrogates to be used to substitute the oil. However, it deserves further attention and investigation about this, because it seems to be very related to the dynamics of embryo culture from the beginning up to blastocyst stage. We have to face with standardization of all these things before of going to automatization, of course. And oil will need an improvement or a change or a surrogate that can face these problems during in vitro maturation or embryo production, in particular for animal models, maybe.
Okay, thank you.
Thank you so much.
Any other question from the audience?
I have another question for all the panel. In the definition of, I'm talking about the culture system, single or sequential. Do you think that we have, I would say we have, enough numbers in the papers to state if the baby has is a big or a low birth or something like that, that depends on the culture system? So the data, because the data that you presented also for the meta-analysis were just two studies with not so many control sample and study sample. So to say something about the baby, you need to have thousands and thousands of baby born. If you consider that you don't even have, for my knowledge, in the literature, thousands and thousands and thousands of embryos that are cultured into different systems, or also day 3 or day 5, doesn't matter, probably you cannot correct anything on the age of the patient and that other stuff. So put a warning on the baby, I think, is always a little bit dangerous. So I would like to have your, of course, all of you, your opinion on that.
Well, actually, this is the most important thing that we should take into consideration, the health of the babies that are born. At present, we do not know which medium is best or which medium is worse. There seem to be differences between medium A and medium B, between medium B and medium C. It doesn't matter if it's a single or a sequential. We know there seem to be differences in birth weight. There seems to be some differences in other neonatal outcomes. I think we are still not certain if extended culture itself, the culture to the blastocyst stage, is 100% safe. So if you expose the embryo for 5 days into an artificial environment compared to 2 or 3 days, is it the same? I think that we are not 100% certain that blastocyst culture itself is as safe as if, for example, we were able to transfer embryos on day 3 and save the extra 2 days of exposure of the embryo in the medium. Up until recently, there were a lot of concerns about the health of children because there were many negative impacts. Some studies that showed a lot of significant differences against blastocyst culture in terms of the health of the baby. Premature labor, large for gestational age, twins, a lot of things. However, it also has to do with the time period that you look, that you analyze. So the modern culture media are not the same as the culture media that we used 20 years ago, definitely. So it's not a very easy question to answer. Definitely we have to think that the lab is not as good as the uterus, and it would be very naive if we thought that it was. So I think we have to use embryo culture as a tool to gain answers, but I'm not against transferring on day 3, for example, if we are certain of which is the best embryo out of the lot.
I'd like to add one
You want
thing.
to make an opinion?
Yeah?
Before there?
I just wanted to
I know that.
To add, Ioannis, that we know that depending on the kind of culture media, we can have slower or faster embryos. So this is the proof that something happens, that they can have an effect on embryo, and why not on live birth?
And also we have to think that what the oldest children born from blastocysts must be in their 20s now. If you think that the majority, that blastocyst culture really picked up after 2000. So we still do not know about the effects of this extended culture into adulthood. And so there are many things that are still unanswered.
Can I? Sure. I agree with you, of course, Ioannis. And looking at the live birth, not only neonatal outcomes, the epidemiologists make a lot about our data, because our studies that correlate neonatal outcomes to culture media are not well designed. So when you speak with epidemiologists that look at these kind of problems, they easily know that there are too much covariates that are involved in, and it's a very danger to concluding that there are some risk in neonatal starting from a culture media. But I agree that this is mainly for two reasons, because humans are very variables. We are not as mouse model, no? So if we collect all data and trying to understand something that is very complicated, without looking at the high complexity of genetics and so on, genomics and so on, it is very difficult to conclude something so strong as a sentence. This is my opinion.
Any other question from the audience?
No, I was just saying the same thing. I mean, to define that there is a difference, we should design a study and correct everything for confounders, because I mean there are all the studies that we have now in the literature have many confounders.
Yeah,
so different.
That's for sure. But I make a suggestion. If you have to consider the real success of IVF, I would get the numbers of the IGMARC. So the word numbers. When we talk about 50%, 60%, 90% pregnancy rate, we are just choosing a low number of cycles. If you have to consider and to say a number, what is the success of the IVF, you have to consider the real life number. So let's say 25%, no more than that. So for that, probably, if a big organization, I don't know if the ASHRE or we can do it, and just put together thousands of embryos, culture with a different system, doesn't matter. At the end, you will have something that counts much more than any meta-analysis that you can have in this field. Okay?
Okay.
It's time for coffee, if there are any other.
Thank you for this, to the speakers for this very interesting session. Coffee break.